I'm going to jump in. If I can get the slides to advance. Here we go. I'm Carla Lopez, supervising attorney for CHAMP at the Community Service Society, as you all hopefully know by now. So today, like I said, we're going to talk about some special New York State law protections related to health insurance coverage of substance use and mental health care. The things that we're going to cover include coverage mandates, which are laws that require insurance to cover certain benefits, utilization review protections, cost sharing protections, network adequacy protections, and a couple of miscellaneous things at the end, if we have time. Acronyms, I will try to say things fully as we go through, but you'll have these slides afterwards and you'll have the list of acronyms if you need them. Okay, so background, health insurance in the United States is governed by a combination of state and federal law. Federal law means law that applies everywhere in the United States. New York State law is law that just applies in New York State. Different types of health insurance are covered by different combinations of state and federal law. So again, we're going to talk about New York State law's special protections and what types of insurance those apply to. So plans that are governed by New York State law, and that little asterisk is just to say some of these are also covered by federal laws, but we're talking about state law in this training. Medicaid managed care plans, Child Health Plus, Essential Plan, Qualified Health Plans, fully insured employer-sponsored plans, the NYSHIP plan, which is New York State health insurance program. That's the health insurance that New York State employees have. And then a lot of local government plans in New York, so like plans that are provided by counties, cities, towns. A lot of those also have to follow New York State law, even if they're self-insured, which is very confusing. Okay, plans that are not governed by New York State law: Medicare, self-insured employer-sponsored plans, and TRICARE and other veterans health insurance. So the stuff we're talking about today, well, in this training, applies to these types of plans. I'll try to keep reiterating that as we go. Okay, so the first thing we're going to talk about is coverage mandates in New York State law for mental health and substance use. So this is what plans governed by New York State law have to include in their benefits. So most plans that are subject to New York State law have to cover these mental health benefits. Let me see, can you move this little thingy? Here we go. Oops. Okay, mental health. Plans must cover inpatient mental health care in a hospital, residential mental health care in an OMH licensed facility, outpatient care that is provided by a psychiatrist, a psychologist, a licensed clinical social worker, LCSW, mental health counselor, marriage and family therapist, psychoanalyst, or nurse practitioner. Notably not on that list, LMSW, licensed master social worker. So they must cover LCSW. They are not required to cover LMSW. New York State plans must also cover outpatient care in OMH facilities. So these are like your mental health clinics, outpatient clinics, licensed by Office of Mental Health, and in crisis stabilization centers, including mobile crisis intervention services, critical time intervention services, and assertive community treatment, or ACT. New York State governed plans also have to cover screening, diagnosis, and treatment of autism spectrum disorder, which we talked about a little bit yesterday, and how that falls into the CHAMP bucket. They also generally must cover care provided in other states by similarly licensed hospitals, facilities, or providers. So we've been talking a fair amount at our monthly meetings recently about Medicaid managed care plans no longer contracting with, for example, some inpatient and residential substance use providers in neighboring states like Pennsylvania Connecticut. You will still see a lot of commercial plans that are governed by state law contracting with those providers. That's the kind of provider that we're talking about here. So care provided in other states that's similarly licensed to New York. New York plans also have to cover treatment in what's called comprehensive care centers for eating disorders. That's like a very specific New York State licensed facility. And then Medicaid managed care plans also have to cover some additional types of mental health benefits like PROS, personalized recovery oriented services, ACT, and harm reduction services, which is super cool. Okay, and then for substance use disorder, New York State plans have to cover inpatient diagnosis and treatment, including detoxification and rehabilitation, unlimited medically necessary residential treatment, which sometimes we have to fight for. Outpatient substance use disorder treatment, including intensive outpatient programs, opioid treatment programs, also sometimes called methadone programs. They have to cover buprenorphine prescribers, and they're also required to cover peer services in an OASIS license program. The new network adequacy regulations that took effect in July of last year also have a couple of coverage requirements. They require New York State plans to have in their networks residential facilities that provide subacute care, assertive community treatment or ACT providers, critical time intervention services, mobile crisis intervention services. So I had mentioned in the previous slide, Medicaid managed care plans already had to cover these. They still have to cover these. For commercial plans, the requirement to have these in the networks doesn't take effect until the state determines that there are enough of these providers in the state. So that's kind of a bummer. Stay tuned. And we're going to talk more about those regulations later in this training, but in the meantime, Medicaid plans do still have to cover these services and have to have them in their networks. And then we have, for some reason, just a whole slide devoted to any telehealth service that would be covered if delivered in person. There's going to be more miscellaneous stuff to put on the slide, but that was all I had. Okay, so case study. Daniel is enrolled in a New York regulated commercial insurance plan through his employer. His therapist is a licensed master social worker, LMSW, who works in a private group practice. Daniel's plan denies coverage of his therapy on the basis that it does not cover services provided by LMSWs. Is this legal? Carmine's nodding. Lots of people are nodding. Such a good question, Kristen. Kristen asked if the person is under a licensed clinical social worker, LCSW. Excellent question. Okay, so most likely it is legal because New York state law doesn't require commercial plans to cover mental health services provided by an LMSW. The commercial plans might cover an LMSW who's billing under one of the other provider types. We've seen that. We've also seen them not cover it. Medicaid plans, however, are required to cover an LMSW who is billing under an LCSW. And there's a link here to a December 2022 Medicaid update from the Department of Health that explains like how that billing is supposed to work. So if you have a client who has Medicaid, they should be able to see an LMSW billing under an LCSW, or I think also they could bill under, don't quote me on this actually. I was going to say they could also probably bill under one of these other provider types, but I'm not entirely sure without checking that Medicaid update that's linked here. But commercial plans, it's kind of up to the plan. And unfortunately, we had a client recently whose commercial plan did not cover an LMSW, even if they were billing under another provider type. Great question.
So finding Medicare.
Now, Medicare is not covered by New York state law, so that's a whole other ball of wax. Cynthia, not to put you on the spot, but does Medicare cover LMSWs now? Yeah, we'll come back to it, but that's a whole different ball of wax, unfortunately. Um, okay, so state law also has special protections that fall into the bucket of utilization review. Um, so our next training is going to be on, where's Alex? Parity. Um, Federal parity laws, as Alex will talk about this afternoon, have been in place since 2008. That's when the Federal Mental Health Parity and Addiction Act passed. So we're almost 20 years in, and unfortunately, we still see so many problems with insurance coverage of mental health and substance use disorder benefits, as you all know. That's why we are here. So New York State has tried to find other ways to hold health insurers accountable and protect the rights of New Yorkers to get this treatment. And this is some of the ways that they've tried to do this through state law. So what is utilization review? It is ways that health insurers manage healthcare costs by deciding on a case-by-case basis what services they'll cover for an enrollee. So it usually has to do with whether something is medically necessary or maybe whether it's experimental or investigational. So when you get a denial of coverage from a health insurer based on like lack of medical necessity or something like that, you're seeing utilization review in action. So common types of utilization review are prior authorization requirements, concurrent review, and retrospective review. These are ways that insurers review treatment to decide if the person, in the health insurer's opinion, really needs it. So New York has created in state law special protections related to the medical necessity criteria that health insurers can use when they're reviewing treatment for mental health and substance use disorder care, prior authorization, concurrent review, and retrospective review. So I'm going to go through the protections in each of these buckets. So first, we're going to talk about medical necessity criteria, which is the criteria that plans use to decide if something is medically necessary. State law protections related to medical necessity criteria. For substance use disorder treatment, all New York regulated health insurance plans have to use the locator. Locator is the level of care clinical review tool that OASIS created a number of years ago. It's something that you can access on the OASIS website. I've linked to it here. All OASIS licensed treatment providers also have to use locator. So that means if you are dealing with an OASIS provider and a New York regulated plan, they should be using the same clinical criteria. And it's helpful because there is meant to be consistency in the clinical criteria that's being used by all these New York State health insurers. And also because OASIS itself created this tool, it is clinically sound. Some of us have probably seen other clinical criteria that is used by health insurers that is bananas, to, I guess, use the technical term, and really not based in like clinical evidence and good care. So this is a great protection that we have in New York. Of course, health insurers do have a habit of misapplying locator when they do their analysis. So what we often do in that situation is we request the locator from the treatment facility and compare it to the one from the plan and show them all the ways that they're wrong and the treatment is needed. So a few years after the state made this requirement that health insurers use locator criteria, a bunch of advocates were like, hey, what about mental health? Because like we're having the same problem on that side. So the state passed a similar law for mental health. And now health insurers have to use an evidence-based and peer-reviewed tool, reviewed and approved by the Office of Mental Health and appropriate to the age of the patient. Unfortunately, there's not like a single tool the way there is on the substance use side that everybody has to use. The tools are supposed to, they're required to be consistent with these guiding principles that OMH issued that are available online. And OMH did say that the following criteria complies with its guiding principles and is presumptively acceptable for plans to use. So locus, cal locus, Casey, I actually don't know, and the SC. Really butchered that, but these tools we mostly use in CSS Champ. We use Locus and Cal Locus a lot when we're doing appeals for clients as like a way to check on medical necessity, argue for medical necessity. But I will say that plans in New York are using other criteria that in theory has been approved by OMH. So it's a little bit messier on the mental health side, but you can always argue that what the plan is doing with their clinical criteria does not comply with these OMH guiding principles, which are quite good. Any questions on medical necessity criteria requirements? The state has also put into place prior authorization protections for mental health and substance use disorder services. So, well, prior authorization, many of us are probably familiar with it, both from our own healthcare and from our work. It's when an insurer has to approve a service before you get it. You have to ask for permission before you get it. Insurers cannot require any prior authorization for emergency services in a hospital or for crisis stabilization centers if the crisis stabilization center is in network and licensed by New York mental hygiene law. I think Ryan Johnson, yesterday you were saying there aren't that many of these crisis stabilization centers yet, but hopefully over time there will be more and more of them. And so when folks seek care at one of them that is in network, there cannot be a prior authorization requirement. So for mental health, New York regulated insurers cannot require people to get prior authorization to get inpatient mental health treatment in a hospital if the treatment is in network and licensed by OMH. They also cannot require prior authorization for subacute mental health care in a crisis residence facility, again, if it's in network and licensed by OMH. For substance use, New York state law forbids insurers to require prior authorization for people to get inpatient, residential, or outpatient substance use treatment if the provider is in network, in state, and licensed by OASIS. So hopefully you all, when you're working with folks who have New York plans, are not ever seeing a prior authorization requirement for substance use treatment in the state. Also, plans are not allowed to require prior auth for prescriptions for substance use disorder medications, including buprenorphine, methadone, which isn't really a prescription, but long-acting injectable naltrexone, which is Vivitrol, and overdose reversal medications like Narcan. For Medicaid plans, this was mentioned maybe in the one of the trainings yesterday. Maybe it was the Medicaid one. That prohibition on required prior authorization for substance use medications has an exception if the medications are not prescribed according to generally accepted national professional guidelines for substance use disorder treatment. Then a Medicaid managed care plan can require prior auth. So you might sometimes see that requirement if somebody maybe has like a much higher dose of buprenorphine than is typically prescribed or something like that. But generally you shouldn't be seeing prior authorization requirements for those medications. And for Medicaid in NYRX, which is, you may recall, the prescription coverage for all Medicaid plans, I believe it actually says what the kind of automatically approved doses are. Any questions on the prior auth stuff?
I just noticed the asterisk that it didn't apply to large groups.
Oh, yes, I'm sorry, I forgot to say that. Yes, that is an important exception. So commercial insurance is can be categorized not only as for employer-sponsored insurance, not only as self-insured and fully insured, but also as large group or small group. So this requirement for substance use disorder prescriptions not to be subjected to prior authorization doesn't apply to large group commercial plans, which have 101 employees in them or more. The plan could still choose not to require prior auth, but it's not like forbidden by law. Thank you, Pam. Yeah.
Just for prescriptions, not for the other.
Yes, just for prescriptions. Any other questions? So concurrent review is the review that an insurer does during treatment. So, maybe somebody's already in inpatient or residential treatment and the provider has to keep asking for approval to keep them longer. That's concurrent review. So for mental health, New York regulated plans are not allowed to do concurrent review for inpatient mental health care in a hospital or for subacute mental health care in a crisis residence facility. If the facility is, this is just going to be the common theme through all of these, if the facility is in New York, in network, and licensed by OMH, and notifies the insurer of the admission and the initial treatment plan within 2 business days of admission. For patients under 18, this applies to the first 14 days of an inpatient admission, no concurrent review allowed. For patients over 18, it's the first 30 days, no concurrent review allowed. There is an exception in the law to this that I have not seen in practice, and I'm not really sure what it means. So I think if you if you see concurrent review happening for someone who is in an inpatient mental health facility or a subacute crisis residence facility, and you're like, why is this happening? I think we would reach out probably to Ryan Gallagher to ask, because it's like if the facility is on some kind of a list or that OMH keeps. So I don't think we would have a way independently of knowing if this exception applies. Mm-hmm.
Is there an example of what the subacute mental health care in a crisis residence facility? Is that like IOP?
No, I think it's this very specific, and Ryan Johnson might want to weigh in, but it's a very specific type of facility licensed under the New York mental hygiene law, of which there are currently very few in New York. So I think we won't see a lot of this right now. I think we're mainly going to see this for like an inpatient psychiatric hospitalization. But we may see more of the crisis residence facilities as there are more of them in the state. Any other questions? Carmen?
I was asking them, what was the definition of subacute exactly? I know it's like stable, but not maybe those who need to be home. So
Yeah.
I was not sure if it's.
I'm using that term because it's the term that's in the law, but I think essentially what it means is residential. But the way that New York State just what's the word, characterizes residential treatment is a little bit different than I think how many of us think of residential treatment. So New York's mental health residential system is really for adults anyway, a lot of it is more like supportive housing, as opposed to like being in a more acute treatment facility. Yeah. So it gets kind of confusing, but yeah, it's basically like a step below inpatient. Any other questions? And then for substance use disorder, there's similar concurrent review protections. So for inpatient and residential treatment, New York insurers can't conduct concurrent review for the first 28 days of that inpatient or residential treatment. Again, as long as the facility is in network, licensed by OASIS in New York State, and notifies the insurer of admission and an initial treatment plan within 2 business days of admission. I think most facilities are pretty familiar with this now. It's been the law since like 2014, I want to say. So I think most of them know to do this. And then outpatient substance use disorder treatment, which includes intensive outpatient and opioid treatment programs. New York insurers cannot conduct concurrent review for the first 4 weeks of continuous treatment, not to exceed 28 visits. Again, if the facility is in New York, in network, licensed by OASIS, and notifies the insurer of the admission and the treatment plan within 2 business days. I do just want to note, sorry, the law does allow for like, I didn't want to get all into this in the slides, but it does say like that the provider and the insurer have to do like periodic consultation, which feels sometimes a little bit like a workaround. Like, okay, the provider still is having to talk to the insurer a lot, but you know, it's not technically concurrent review, but they might still need to talk. Okay, so retrospective review. We've got prior, concurrent, retrospective. This is like after the treatment has already occurred. This is when the insurer looks back at it and decides whether it was medically necessary. For mental health, inpatient and residential mental health, if the care is denied retrospectively, the patient can't be liable to the facility for any cost other than their cost sharing. That's New York State law for New York State insurance plans. More robust protections on the substance use disorder side. So for inpatient and residential substance use disorder treatment, right? So you weren't allowed to have prior auth. You're not allowed to have concurrent review for the first 28 days. If the insurer then, after those 28 days, wants to look back at the treatment and decide if it was necessary, they're only allowed to deny those first 28 days if the treatment was contrary to that locator tool. That's the medical necessity criteria that the provider and the plan both have to use. If they find that the treatment was contrary to locator, then they can deny it retrospectively, but the patient cannot be liable to the facility for the cost of it other than their cost sharing. Very similar protection for outpatient substance use disorder treatment. So remember, no prior auth for outpatient, no concurrent review for the first 4 weeks, 28 visits. After those 4 weeks or 28 visits, if the insurer is going to look back and, you know, determine whether that was medically necessary, again, they can only deny it if it was contrary to locator. And if they do deny it on that basis, then the patient is not liable for anything other than their in-network cost sharing. Any questions on that? It's really just a group of protections that taken together are meant to allow people to get treatment for a period of time without hopefully having to fight with their insurance company. Okay, case study. Katerina, oh, these are my Daniel Tiger names. Okay. I was like, what? Katerina is enrolled in a Medicaid managed care plan. She's admitted to a residential substance use disorder treatment facility that is in network, licensed by OASIS. After 28 days of treatment, the facility tells her that she will be discharged because her plan only covers a maximum of 28 days of residential substance use disorder treatment. Is this allowed? Any thoughts? Could shout them out.
No.
Pam doesn't think it's allowed. Bradley doesn't think it's allowed. Get Pam pulling out that slide from like 15 slides ago. Pam remembers that I said unlimited medically necessary.
Yeah, that's the key is, it's still not necessary. We can say, this is how much we can provide.
Right. Bradley is saying the key is whether it is still medically necessary or clinically indicated, but you can't say that there's a maximum. And you guys are right. So again, they have to cover unlimited medically necessary residential substance use disorder treatment. There can't be a maximum. Any thoughts on next steps to help Katerina? also known as Katerina Kitty Cat on Daniel Tiger. What's that? Bradley says request a locator from the insurance company. Great idea. Signs out.
Residential.
Yep, Bradley says find out if it's still medically necessary for her to stay. Great point. That's the very first bullet here. So does the facility think that she still needs treatment? That's really like the first question. They might think that she is ready to step down, and then there's not really anything to fight with the insurance company about because her treatment provider doesn't think she needs further residential. If the facility thinks that she needs more residential treatment past those 28 days, we would normally ask them, did you ask the plan for more? Because a lot of times they don't. A lot of insurers and treatment facilities, even though this isn't what the law says, they take that sort of minimum and they turn it into a maximum. So a lot of the plans are like, oh, well, yeah, we did the 28 days, so we're done. And it's like, no, that's the minimum, not the minimum treatment, but the minimum treatment someone can have before you start reviewing it. And a lot of providers view it as a maximum too, because they're used to insurers denying it after the 28 days, so they don't even ask. So, you should find out if the provider even asked for more time. If they didn't, see if they will. If they did ask for more time and it got denied, get a copy of the denial. They can appeal the denial, the provider, or we can help them appeal the denial as well. Checking my time. Yeah.
For commercial plans, are they allowed to be more stringent around the practice? Like an example here, we're talking Medicaid managed care, so a commercial plan can be more stringent or not?
Not if they're regulated by state law. Yeah. Self-insured plans, whole other beast, but yeah. Okay. Cost sharing. When we talk about cost sharing, we're talking about deductibles, co-payments, co-insurance. That's cost sharing. And this is another area where New York has tried to protect people who need mental health and substance use treatment. So for mental health, if someone is receiving outpatient mental health services in an OMH licensed facility, their co-pays and co-insurance cannot exceed those imposed for primary care office visits. No specialist fees here allowed. For substance use disorder, opioid treatment programs. So these are methadone programs for those who are, yeah. No co-pays or co-insurance allowed at all if someone has New York State regulated health insurance, which is fantastic for our clients. Outpatient substance use disorder services. This is similar to the mental health one. Co-pays and co-insurance cannot exceed the primary care office visit, co-pays and co-insurance. And for outpatient substance use disorder services at an OASIS licensed facility, they're only allowed to charge one co-payment for all services provided in a single day. So somebody might get multiple services in the day, like maybe they have an individual session and a group session in the same day. They can only be charged one copay. And that last one only applies to large group plans, 101 or more employees.
Can I just clarify on the previous slide about mental health? So if someone is receiving services at a private practitioner, their co-pays can be higher. This only applies to OMH cardholder homes.
Yes, this protection, Ryan is asking, would this apply to somebody who's getting services from like a private practice? And the answer is this New York State law would not apply. So somebody who is seeing like a private therapist could be charged a higher copay under New York State law than they are charged to see their PCP. But another teaser for the parity training coming up, that might violate parity laws, which require some equality between benefits.
And those are for parity put into the same bucket as comparable services.
We would argue that they are, yeah. And yeah, Alex will go over the different classifications that benefits get put into under the parity law, but yeah, we've definitely made that argument. Any other questions?
I just had a comment about participating versus non-participating. Because there's a lot.
There is the rub. Sorry, Pam is, I don't know if everyone can hear on the Zoom, but participating versus non-participating, but we are going to talk about that too. Okay. Any other questions? I did just want to note, we talked yesterday when Sam gave the Medicaid training about the other cost sharing protections in Medicaid that I'm not reviewing here because they aren't like specific to mental health and substance use disorder, but just remember that there are absolutely are limits to what folks with Medicaid can be charged for cost sharing. Case study. Elena has insurance coverage through her partner's employer fully insured health plan. Her partner works for a company with 250 employees. Elena is receiving treatment at an OASIS licensed in-network intensive outpatient program for her substance use disorder. On days when she has both individual and group therapy, her plan charges her $25 for the individual therapy and $25 for the group therapies for a total of $50 for the day. Is this legal? We got a resounding no from the room, and you're right, it's not legal. So we just talked about this. They can only charge one copay for a large group plan, only one copay for all of the outpatient services received on the same day in an OASIS licensed substance use disorder facility. Any other questions before I talk about network adequacy? A little bit, okay. Okay. What is a network? I think folks know this, but most plans contract with a network of healthcare providers that are considered in network and have rules about using providers that are outside of that network. Network adequacy is a term for an insurance plan's ability to deliver the benefits that it promises by providing reasonable access to enough in-network providers for all of the health services covered under that plan's contract. New York state law says that a health plan shall ensure that its provider network is adequate to meet the behavioral health needs of insureds and provide an appropriate choice of providers sufficient to render the behavioral health services covered under its health insurance policies and contracts. Basically, like if your health plan says it covers inpatient, outpatient, residential, do they actually have providers to deliver those services that it says that it covers? And insurers have to cover some services even if the provider is not in the network. So that would be emergency services in a hospital, OASIS and OMH, mobile crisis intervention services, and covered outpatient mental health care provided by a school-based mental health clinic. So if somebody does need one of those three services and they get it outside of their network, the plan can't charge them more than their in-network cost sharing. So there's different types of standards that are required by law as a way to get at the adequacy of a network that I'm going to go through. So the first one is wait time requirements. This is one way of measuring whether a network is adequate. And actually, before I jump in, so again, you all, I think, know that in July 2025, new New York State network adequacy regulations specifically pertaining to mental health and substance use took effect. So I'm going to kind of flag where I'm talking about those new regulations because now there's sort of this overlay of like what was already in the law and now these new regulations. So New York state law says that plans have to ensure a network has adequate capacity and availability of mental health and substance use disorder providers to treat the members' mental health and substance use conditions. I put this little flag here so you would know when we're talking about the new regulations, this one down here. The new regulations say that a health plan has to have an initial appointment with an outpatient facility or clinic available within 10 business days of when the person requests it. And also an initial appointment with a healthcare professional within 10 business days. And I put the definition of healthcare professional on the slide here, but basically plans are supposed to have an outpatient appointment available within 10 business days. And if somebody has just been discharged from a hospital or an emergency room, this appointment has to be available within 7 calendar days. These wait time standards can be met with telehealth unless the person specifically says they want an in-person appointment. And New York insurers are supposed to post these wait time requirements on their websites. And I will say, I rarely have seen this on an insurer's website, but it's supposed to be there. I do want to flag that, so these are the new requirements in the regulations that apply to all New York regulated plans, Medicaid, commercial, essential plan, Child Health Plus, etc. Medicaid managed care, before these new regulations came into being, already had wait time requirements, and a lot of them are stronger than what's in the new regulations. So where there are stronger requirements in Medicaid, we apply those. So Medicaid has to have certain services are supposed to be available immediately, which is emergency care and CPAP, or CPAP, Certified Psychiatric Emergency Program. Is that right? CPAP? Psychiatric emergency rooms. Inpatient mental health is supposed to be available immediately upon presentation. Inpatient substance use disorder detox, crisis intervention services. Medicaid says that the following must be available within 24 hours. Urgent care, urgently needed inpatient or residential substance use disorder treatment, urgently needed outpatient mental health or substance use disorder treatment in an OASIS or an OMH clinic, opioid treatment programs. And then they have some other standards, pretty much all of which, other than non-urgent behavioral health referrals, have to be available more quickly than what's in the new regulations. So just keep in mind, again, this is the requirement. This is not often the reality on the ground, as we all know, but it is a tool for us to argue for what our clients need. Yeah.
So, Pollination Oasis put together a crosswalk, little like cheat sheet of these Medicaid non-care contract requirements, as well as compared to the new network advocacy. I really tried to get it for you today, but we're waiting on DOH and DFS to say it's good. So as soon as that's approved, I will send that out to the network for you all to.
Thank you, Ryan. And if folks on the Zoom couldn't hear, OASIS and OMH are did make a crosswalk of these different wait time requirements that Ryan will share with us as soon as it's approved for public consumption. Thank you. Or CHAMP consumption anyway. Any questions on the wait time requirements?
Yeah, so when this happened. I just had a case where someone had 9 they just called the area as one person in the building. So their wait time is gonna be a lot longer than they had the Dallas.
Mm-hmm.
So is this something I bring up to the clinic? Is this something I bring up to, I put in a sentinel?
The plan. The plan, yeah. Can folks on Zoom hear the questions, or is it helpful if I repeat?
Some of them we can hear, some of them we can't. That one was not easy to hear.
Okay, thanks, Geneva. Mackenzie was saying, like, what do you do if the clinic doesn't have appointment availability within these timeframes, and who do you tell? And I was saying, you know, the place that you typically would go is the plan. I'm gonna talk in this section about what to do when networks are inadequate or can't meet these standards, because there's sort of two pieces here, right? There's what exists, like what healthcare exists where you are, right? Because we can't, as CHAMP, materialize treatment providers that aren't there. But if the treatment providers are there and they're just not covered by the health insurance, then we have a lot more options. So we'll talk a little bit about what those options are if there is in fact a provider and it's just not covered. Thanks. Travel time and distance requirements. I'm going to go through this kind of quickly. There's a sort of general 30-minute, 30-mile rule. I'll just say that for now, for time and distance if somebody wants an in-person appointment. And if there's nothing within that radius in the network, then they're not meeting their time and distance requirements for network adequacy. Provider directory requirements. Provider directories are required by state law and by the new network adequacy regulations to include a bunch of information, including what restrictions exist on the availability of services. So for example, if a provider in the network, this is specific to mental health and substance use. If they only treat children, if they only treat cancer patients, things like that, it's supposed to say it in the network. It's also supposed to be specify the level of care offered, and the other things listed here, whether there's telehealth, whether there's what languages are spoken. The directory of mental health and substance use providers is required to be publicly posted on a publicly accessible area of the plan's website, which is kind of a big deal because in the past we have seen plans refuse to share a list of their network providers with advocates. So it is supposed to be publicly accessible now on their website and searchable and filterable by these things. And the plan has to allow the consumer or their designee has to provide them with a list of providers who can treat their specific conditions within 3 business days of a request. So if you can't find what you need in the online directory, and you ask the plan for an in-network provider who can treat you, they have to give you that information within 3 business days. I'm going to skip most of this, other than the plans are required to have a method publicly available on their websites to report directory errors, and those errors must be corrected within 15 business days. This is another thing where I would say, rarely have I seen a health insurer have a publicly accessible way to report directory errors, but they are supposed to have this publicly available on their website. And if they don't, we can report it to a regulator. Plans are also required under the new regulations to have a designated staff person or people with sufficient knowledge to help consumers find mental health and substance use disorder providers who can treat their condition, and their contact information is supposed to be publicly posted on the website. Again, very rarely is this information publicly posted on websites. I will say our very own Laura Holdridge recently had success after asking a plan, where is this information on your website? They looked into it and they put it on their website. Amazing. So if you don't see this stuff on the plan's website, you can tell them they're supposed to have it and you can report them to a regulator for not having it. I am, yeah, I think I'm gonna skip this one. Because this is important. Inaccurate provider directories and the protections that go along with them. If a plan tells somebody that a provider is in their network and they're not, the plan has to cover it as in network. They are liable for the cost of that treatment. Okay, access requirements. This is getting a little bit now to Mackenzie's question of what do you do? Oh, sorry, go ahead, Ryan.
As champ advocates,
Mhm.
how important is it, like, so I'm just thinking of like. A therapist who's listed as a network, reached out to, hey, you know, I have this insurance, and he says back, I don't take that anymore. As a champ advocate, is it like, well, it's listed, so go ahead, or is it one of those like, okay, well, the therapist knows that they're not in network anymore, and you know, you should look somewhere else, despite the fact that this law exists?
So I would say as advocates, if the provider is saying I'm not in the network, and the network says that they are, I would report that to the plan as an error and tell them to correct it. I wouldn't typically recommend that somebody start treatment with that provider because then, you know, yeah, they might go and then the plan has to pay for it, but it's going to take a lot of fighting. And then they're going to have to stop treatment and start with somebody else once it gets sorted out. So this is usually more of a like after the fact protection. If somebody comes to us and is like, I started going to this place, it's listed as in network with my plan. They told me they were in network. Now suddenly it's being denied as out of network. What should I do? And then it's like, well, they have to cover it. It's here. I will say, downloading and saving provider directories is great. Taking screenshots of them is great. If it's information that was provided over the phone, getting even like the name of the rep or the date that you called, a call reference number is always fantastic, but most clients, if they've done this before coming to us, wouldn't know to get that. But we love receipts. Makes things easier later on. Thanks, Ryan.
Are there any protections for the opposite scenario if the provider says they are on network with the plan and rejects the being out of network?
So Donna's asking if there's protections for if the provider says that they're in network, but the plan says that they're not. In that situation, I mean, we would usually try to confirm independently with the plan, like whether the provider is or is not in the network. If the provider is really out of network and they just gave the person misinformation, if it's a Medicaid accepting provider and a Medicaid client, then we would say like, well, you can't balance bill this person, so you're gonna have to eat that cost. If it's not Medicaid, usually what we would do is engage in like debt negotiation with the provider, and advocate for like a reduction or forgiving of the bill, especially since it's their error. And, we have been successful in doing that. Yeah. It's a good question. Okay. So I'm gonna try to just quickly summarize some of this. We have like full-length trainings on this available on the portal. We're also happy to give these full-length trainings on this stuff again at a monthly meeting if that would be helpful. The new network adequacy regulations give people the right to file what's called an access complaint if a plan cannot meet the wait time requirements in the new regulations. This can be by phone or in writing, and plans have to have on their websites information on the right to file an access complaint and how you do this. Many of them don't, but they are supposed to. If somebody files an access complaint, which, for at CSS with our clients, usually we just call with the client and say, like, we want to file an access complaint. Sometimes they have no idea what we're talking about. That's information to know and follow up on. And sometimes they do know what we're talking about. So if you file an access complaint, the plan has 3 business days to respond. They have to respond in writing and also by phone if the complaint was a phone complaint. And they have to, within 3 business days, tell you, were they able to find an in-network provider who can do what you needed and meet the wait time standards? Or if they couldn't, they have to say, you can go out of network now because we don't have anybody. So if it's the latter, if they say we can't find anybody who can meet the wait time standards and who can do what you need, they have to say, like I said, that you can go out of network if the out of network provider meets these requirements. The rub, of course, is that the provider is supposed to charge rates that are not excessive or unreasonable, the out of network provider. This is not defined in the law. Like, what does that mean? Excessive or unreasonable? We would argue that anything that is consistent with like the Fair Health rates. I'm not sure if folks are familiar with Fair Health as a tool. If you're not, we can share it, but it's a website that where you can get information on like what rates different types of providers charge in New York State. If the plan says you can go out of network because we don't have anybody in network, they cannot impose anything on the consumer beyond their in-network cost sharing. The new regulations that lay out this access complaint process don't say like what is supposed to happen after a plan says we don't have anybody in network, you can go out of network. So we recommend that at that point, the client commence the out-of-network referral process, which was already existing in state law before these regulations came into being. The state has expressed that they think that in this situation, if somebody requests an out-of-network referral, it should be quickly approved because the plan has already said they have nobody in network. In reality, we have seen this not work in that way, but we're continuing to do this for folks, and all of you can and should as well, and we're happy to help. And we're continuing to share with the state what we're seeing about how this is and isn't working. We just reminder, out-of-network referrals. New York State law says, separate from these new regulations, if a plan does not have an in-network provider with the training and experience necessary to meet the insured's particular healthcare needs, they have the right to an out-of-network referral at no cost to them beyond their in-network cost sharing. The plan has to tell people how they can request this out-of-network referral. If they deny the out-of-network referral, the person has appeal rights. The appeal rights are pretty specific when it comes to this stuff. So please reach out to us if you have a client who requests an out-of-network referral and gets denied, and we can help with the appeal process. But that kind of denial can actually be reviewed. It can be put into a utilization review appeal process, which means they get external appeal rights too. So it's actually like a pretty important right that we use often at CSS for our clients who cannot get the care they need in their network. So it's just a really important tool to keep in mind. Usually the process for requesting an out-of-network referral is similar to like a prior authorization process. So it usually is like the prior auth form, and I'd say often it's the provider who requests it, but sometimes the client can request it themselves. And we do have like a whole training on this and can do more training on this. And I'm over time, so boop, boop. Oh, those are the trainings. So these are trainings that are already in the portal if you want like a refresher on some of these concepts. And again, if you would like another training that just goes more into depth on this network adequacy stuff and the out-of-network referrals and all of these things that are confusing but super useful, let us know. We can do them at a monthly meeting. Okay, I'm going to wrap up.